might need that color.
I actually don't have like the grid, you know, but just pretend this is a long distance. Because I don't have like the lines. So yeah. What is this?
Bradycardia.
Good. So we'll see this. We're gonna first thing you're gonna do.
Check the patient.
What does that mean?
We're making sure they're alive, they have a pulse, they're not lightheaded.
Well, I just asked because since they check the patient, they're like checking. All right, I've checked. Like, didn't actually do anything, you know?
Hey, how you doing?
So what are specific body things that you're gonna check?
Their pulse.
So we're looking
level of consciousness.
Sometimes the leads in the hospital, they suck. Sorry, they do. Like you want to assess O2, right? Because that's going to be part of whether they're symptomatic or not. Because they can have a really low heart rate and be tolerating it fine, right? No problem. Like what's the guy who did the bike thing? Lance Armstrong? Is that the guy?
Well, there's one guy who had a really low.
Yeah, and because he's just so in shape and he's good, right? The only reason it would be a problem is if they're not perfusing enough, right?
So if it's symptomatic bradycardia, that's where we have issues, right?
And symptomatic would be if they're just feeling super like exercise intolerance, like they don't feel like they can go upstairs or do the things that they normally would be able to. If their respiratory rate is like higher to try and get that oxygen, because the blood carries the oxygen, right? So like your muscles require oxygen when you move. So if they're feeling short of breath, or those different things, then they're symptomatic. Right, so then, assuming they're symptomatic, then what are you going to want to give them?
Atropine.
I was just about to ask, what does it do? So it increases heart rate. Do you know why it increases heart rate?
That's the next.
It works on the
Yeah. So it blocks the parasympathetic, right? You know they talk about receptors at all?
Yeah.
Okay. So like if this is like a cell or whatever, everything has receptors. A lot of drugs will compete for the same receptors. So atropine binds to it and it blocks the parasympathetic nervous system from attaching to it. So where's the eraser? So good. Do you guys have to know like how often and how much atropine you can give? Is that part of your things you have to know?
1 milligram. Repeat every 3 to 5 minutes. Maximum 3 milligrams.
Perfect.
So repeat 3 times.
Perfect. Okay, so you got a person that they got bradycardia, they're not handling it well, they're feeling short of breath, their oxygen's low, so you give them atropine. And what else would you want to give them? Also, not necessarily medication, but to help them. Oxygen, right? So let's say they're not responding well to atropine, it's not really doing anything. So what can you give them then? It's not necessarily a drug, but a treatment. Yes. If they're not responding to this and their heart rate still stays low,
A defibrillator, like low, what do they call that?
Transcutaneous pacing.
Pacing, that's it.
Yeah.
It was like the low electricity.
What does transcutaneous mean?
On the outside of the skin.
Trans means through, like transport, you're like going through one city to another. And then cutaneous, what is that?
Skin.
Yeah, so through the skin, and it's it looks like a defibrillator, kind of, like the pads you put here, and it's like a pacemaker that like the ones you see the little bump they have on their chest, except you don't have to have like surgery to put it in, right? It's temporary. It's an external pacemaker, essentially. You use that until you can go schedule something else, right? So if they're just like, oh man, this isn't good, atropine's not working, we can do transcutaneous pacing until we can schedule them for actual pacemaker or something like that. That makes sense?
So basically that's if atropine doesn't work.
Yeah.
If they're not responding back.
Yeah. Some patients just don't respond to stuff, things work with certain people, not others. Any questions on bradycardia?
Wouldn't that be is that supposed to be a 6 strip?
I'm just trying to make it more dramatic, like, okay, this is long. If it's unclear, I'll explain. Yeah. If it was normal, I'd put
Imagine this is a 6 second stroke.
Sure.
Okay.
Can I erase it?
Yeah.
This one will be very easy.
AFib.
Well, not quite.
Is
Huh?
that flutter?
Yeah.
Atrial flutter. Okay, that's AFib. Oh.
Squiggle.
Okay, I was like, what a T-word?
Well, you know, because flutter and fib is just kind of random. Flutter is more like a regular, like saw,
Okay.
and AFib is just kind of like, just like VFib. You know, like VFib is like this, you know. So this is just in between the QRSs. So if you give QRSs to VFib, it's AFib basically. Okay, so this is happening. What's the one thing? What the first thing you're gonna think of is potential for?
Clots.
Yes. Why?
Because the atrial recovering and the blood's not flowing, so it's in the atrium.
Yeah. So
So
like,
like, sitting.
yeah. So you ever seen like a nasty lake with like the scum on the top? Like in flowing water, like rivers, you don't see that because it's constantly moving. But it's like when it just sits there stagnant, it gets like gross. The same thing with the blood. Like if the atria isn't squishing all of it like a river, you know, it's constantly flowing, it just kind of backs up and pulls there. It forms like nasty like clot stuff. So where do you want to give this person? What are they going to be on for life anyway? Yeah. So Coumadin, Xarelto, something like that, right? Now, if someone has this and they came into the hospital and they said, "Oh, this just started." If it started within 48 hours, they say it's only cardiovert because they assume that you haven't built up that many clots yet, because it takes a minute for like the clots to form. It doesn't happen like, oh, you just had AFib just now, you have a clot already, right? It takes a minute for the blood to pool. So within 48 hours, right, you can do cardioversion. If it's been longer than 48 hours, you can still do cardioversion, but you have to do what? Yeah, the TEE, right?
Yeah, check.
Transesophageal, what is it? Yeah, thank you. So what does that actually, like, sometimes like we throw around these names and we don't actually know what it means or what it
We
does.
go down the throat and look at the heart behind the better image. They can also look, I think, from below.
It's like a reverse
Yeah.
image, right?
Yeah, so you can actually see like, oh, there's clots there, right? And if there is, what are you gonna do?
Not.
Right,
No,
you're not gonna cardioversion then,
Cardiovert.
because if you give them a cardioversion and they have clots, you're just shocking
There's
some
lots.
clots out, right? And that's bad. But what can you give them in order to be able to cardivert them later?
The anticoagulant.
Specifically, what?
Heparin or
Yeah, they'll most likely do a heparin bolus. You guys talked about that in class at all? So generally, like if someone goes home on heparin, they're not gonna get like a bolus, right? They're just gonna get like a maintenance dose, like a little bit. But if they a heparin bolus, what that will do is like immediately bring them up to the therapeutic level, like within a short period of time, so that they can like make sure no new clots are forming, break down clots that are there. So then you have to be on it for, I forget how long it is. You have to be on the heparin for a certain amount of time before it's safe to do a cardioversion, so you're not shocking clots into their body. Yes. What other types of meds or antiarrhythmics is used for?
yeah, it's just beta blockers and calcium channel.
Yeah, amiodarone, calcium channel blockers. Yeah, good. Pretty good on this one. Go ahead and erase.
She did have a star amiodarone.
Yeah, amiodarone is becoming more and more used.
Okay. She doesn't have a star in particular sodium channel blocker. I did underline lidocaine.
Lidocaine, and I was going to mention this later, but lidocaine is becoming less used, just because we got better drugs. But also, there's a pretty bad side effect with lidocaine. Do you guys know what that is? I don't think it's that one. But the one I'm thinking of is sudden death. So I'm like, that sounds bad too, but sudden death I think trumps the other ones. So, I mean, people still do use lidocaine, especially if people got a bunch of allergies, and it kind of limits what you can use. Like, if someone's allergic to amiodarone, I mean, like, well, you got to give them something, right?
No, neurotoxicity is
Yeah.
and you need to be ACLS certified.
Like, lidocaine is one of the ones in the crash cart, along with epinephrine, sodium bicarb. I think atropine's in there too. All right, this one, another easy one. Yeah. This one's V-TAC. This one,
That's VTAC. Okay.
aren't my drawings the best?
VTAC is more pretty.
Right, this one is just completely random. It just looks like a child went, like that. This is just literally like M's, right? Just or W's, however you want to look at it. The reason why I put AFib and aflutter together was so you can differentiate what the two look like, but also because the treatment's pretty much the same. Like, I mean, the rhythm looks different, but the treatment, really, we treat them both alike. Kind of the same thing with these two. They can kind of look similar, especially if like these are taller. If these little notches get taller, you might mistake one for the other. And also the treatments are pretty similar too. So if you're sitting at the nurse's station and the monitor goes off and you see this, either one, on the monitor, what's the first thing you're going to do? Right. So again, the hospital leads, like in school, you think that everything's in a perfect world, but in real life, like patients are constantly getting up. They've got these leads on. One's dangling the floor. They're trying to drag an IV pole going to the bathroom. A lead will be stuck to the IV pole, and it's picking up all sorts of stuff. We call it artifacts. And did they talk about that in class? I don't know. But like it'll be picking up stuff that isn't necessarily their heart, right? So like you might see this and like, oh my gosh, and then like call a code, and then you're embarrassed because like they're actually just fine. They're like, oh, what's going on? Like, and yeah, they're like, why is everyone here? It's like, oh, I didn't check them to see. Again, so when we say check the patient, what are you checking to see?
Level of consciousness, pulse.
Yeah, are they conscious? Right. One, do they have a pulse? Are they breathing? Right. So let's assume they are conscious. Right, and they have a pulse, but it's actually true. Like this is their actual true rhythm.
Rapid.
Yeah. So call rapid. What else can we start? What's the one energy option we're gonna
Synchronized cardioversion.
Right. So it's cardioversion. So what's the difference between the synchronized and the unsynchronized? I tend to just call it cardioversion and defibrillation.
Like synchronized, like you have to sync to the R.
Yeah. Yeah, so
And you have a pulse with this one.
And you have what?
You have a pulse with cardio.
Yeah.
Synchronizing with that pulse.
Right. So we can't, it'd be very impossible for us to like do it ourselves. Be like, all right, now shock now. Like, cause it happens so quick. So like the machine does it for you, and so it'll time it. I think she said, what's your name? Nice to meet you. So like it'll time it right on the R to like shock at just the right moment so that it'll like get, I don't know why, but that's what it does. And yeah, so the synchronized is the conscious of the pulse. Now, what if you find them and they are not breathing and they do not have a pulse?
So it'd be asynchronized.
Yeah, or
Cardio.
defibrillation. Yeah, and the other thing I don't think I mentioned too is the cardioversion is a lesser shock because it's timed perfect. It doesn't have to be as strong. Whereas the defibrillator, it's just kind of given random, so it's a much stronger shock as well than the cardioversion is.
Is asynchronized cardioversion the same as defibrillation? Yeah, that's what it's.
Yeah, I tend to call it just cardioversion and defibrillation. You'll hear that a lot. A lot of people don't say synchronized and asynchronized because it just takes too long. So if you get confused.
The synchronized cardioversion.
Yeah. I just tend to say cardiovert or defib. That's just kind of what I tend to hear. But if you get confused, don't feel bad to ask. So if they don't have, before you just stand around and wait, call a code, they're not breathing, no pulse, you're waiting for the crash cart to come, what are you going to start doing? CPR.
Chest compression.
Good. Not just stand there waiting like, okay, I'm going to wait for the defibrillator. Like, no, like, start compressing, right? What else? Okay, treatments. Other than medications, what are some other things we're going to do? So we can put what on
Get the oxygen on them.
Right. Because the biggest issue, we don't tend to think about respiratory, we don't think about heart, but like the heart is pumping the blood, which carries the oxygen, right? So the problem is that oxygen isn't getting to the body, right? So, yeah. And so we need to get oxygen on them to saturate what blood is going to where it needs to go. Does that make sense? Okay, so meds. What meds are we giving?
Amnio.
Amnio.
So I have for torsades, we can give max sulfate.
Oh yeah, I haven't gotten to that one yet.
Okay.
It's making sure I'm not in the way.
Or lidocaine for monomorphic, which would be
Yeah, this one
regular beta.
probably not going to be your go-to. Your go-to probably is going to be epi, right? Epinephrine is pretty much the one that's given for any life-threatening rhythm.
Is that for the pulseless or for both?
Just any life-threatening rhythm. So this,
Okay.
yeah. So like you'll see that with VTAC, VFib, asystole, and PEA, pulseless electrical activity. Generally, again, this one probably isn't going to be your first one, just because there is the complication of potential sudden death. I see amnio and epi way more. Not to say that lidocaine isn't used. Does that make sense? So, but yeah, it definitely is given. It's in the crash cart. You were asking about torsades. So, what does torsades look like?
It gets smaller,
Yeah,
and larger, and
It's fun to make all that. Yeah. So if you see like undulating, like that word, that'll clue you into there's an electrolyte problem. We don't think about electrolytes like impacting the heart, but like potassium, sodium, calcium, all of these things impact the heart a bunch. So yeah, giving mag, definitely a big one if you see this, along with whatever else you're doing. Is it okay to erase this? Yes, VTAC with torsades and VFib. VFib and AFib are the same, except AFib has a QRS. So if it had a QRS, it'd be AFib. Does that make sense?
because it's the atrium,
Right.
and the QRS is the ventricles.
Yeah, exactly. That's an easy way to think about it, I
So
guess.
the weird looking one is like electrolyte imbalance, whereas like the regular one just like.
Yeah, so regular VTAC, all the same.
Yeah.
VTAC with torsades,
That's
Still
electrolyte.
pretty though.
that's pretty. So I don't think
It's
you're
not pretty.
I don't think you're gonna want
It's
it.
not the right word
Yeah.
to use.
Erase it.
Smooth. I'll say smooth.
When in doubt, epi is like a good choice if it's life-threatening rhythm and you're not sure about the other answers and epinephrine's on there and they have something life-threatening, it's a safe bet.
Is it true that on the NCLEX you assume that everything else is perfect other than what they're talking about? Like,
Yeah, because you can overthink. Like, what
Exactly. Okay.
If, what if they have a history of COPD?
Right.
And like, is that in there?
Are the leads on perfect? But you just assume
Yeah.
they're on perfect.
Yeah.
And then-
It's like, but what if they have severe heart cancer? It's like that. Let's not overthink this, you know. Anyways, but it's easy to do that because you want to think like that in real life, but for the purpose of the question, they're trying to like draw out one specific nugget of information out of you. So, all right, let's look at my next one. Okay. Try to do this one as best I can. I'm just trying to smush it real good together. So the sinus attack. Okay, so this is similar to sinus brady in the sense that like, are they symptomatic? Are they having problems? Is it bothering them? Are they tolerating it well? So interestingly, you'll have kind of similar side effects with sinus attack and sinus brady. Obviously except for the heart rate being high and one being low, but like, feeling, short of breath, kind of like tired, like exercise intolerance. You walked in like right after you finished bradycardia, but you're gonna have similar symptoms because in both cases, whether it be super slow or way too fast, the heart isn't adequately pumping, right? So the cardiac output is still affected, right? So no matter if it's going too fast or too slow, you're still not getting great output, which means you're not getting great perfusion, which means you're not getting great oxygenation. So either way, you're gonna feel kind of tired or worn down. Does that make sense? So if they're not tolerating it well, kind of a trick question. How would you treat it? Yes, that is, you would. I guess the part of the trick question is you don't know how to treat it unless you know what's causing it. Because this can be caused by so many different things. I bet you a lot of you are going to have this rhythm when you go in for NCLEX, right? Like anxiety and stress, and put someone in sinus attack, right? And I hope someone wouldn't give you a beta blocker immediately. They would just try some soothing relaxation techniques, right? So what are some causes? Let's say
Exercise.
Caffeine.
yeah, definitely. Yeah, this is totally true. When I drink coffee, I'm tired still, but just my heart rate is like now 150. So it's like I can't.
Probably not healthy.
Yeah, it's really not helpful.
Maybe guy.
It's not the best. It's like I still feel tired, but my heart rate is just really fast, so not the best. Caffeine. Someone said exercise.
Medication.
Yeah, so
Yeah.
if you're out of shape, exercise will do this to you. If you're super in shape, it won't. Like the bicycle dude. What was Armstrong, right? That's his name. Lance Armstrong? Yeah, okay. That was crazy. I was thinking, no. I'm thinking of, I was thinking of Neil Armstrong.
Yeah.
Okay, I'm not crazy. Perfect. What else? What else increases heart rate?
I was thinking some medication, but I can't think of anything that way.
What about substances?
Right, okay, drugs.
Other than
cocaine.
Nicotine.
Yeah.
What do we know about nicotine? Other than it's addictive and it's cigarettes. Vasoconstrictive, right? Alcohol, interestingly enough, and
Oh, really? Okay.
yeah,
I
it's
thought that was a depressant.
yeah, it is, but some people,
Interesting.
it says any substance can make you weird. You know?
So cocaine is a big one, isn't it?
Oh yeah, for sure. Okay.
I've just seen a lot of that. There's a lot of people on cocaine.
Think hormonally. Is there anything you think of hormonally that would increase your heart rate? Perfect. Hyperthyroidism. So increased thyroid. And what?
Low, like hypothyroidism.
Well, that would give you more like breathing.
Dehydration?
Yeah, dehydration. Perfect. Like
I was thinking DI, actually.
Yeah.
When you said hormones, diabetes insipidus. And
oh, I was like, what's
dehydration.
DI? I was like, DI.
Diabetes insipidus.
Yeah. The one I'm thinking of is anemia, which is similar to dehydration or hypovolemia because you have less blood, less oxygen, so you're essentially having less cardiac output, essentially, even though your heart's pumping, you know what I'm saying? So your body's gonna try and compensate for thinking it has less by tachycardia. So lots of different problems, right? So how do you treat it if you don't know? Right? So someone comes in with this, you're like, shoot, you gotta do like a full workup, right? Because you don't know. So if it's stress, relaxation, caffeine, stop. Exercise, maybe go to the gym and work your way up. Nicotine, stop. Alcohol, stop. Cocaine, please stop. Thyroid,
I need to take TH. Or no. What's the drug?
The ones that are.
yeah, usually, a lot of people have to get like their thyroid removed, and then take replacement hormones that are like lesser than what they were secreting.
What was the drug that suppressed? I thought there was a drug that suppressed the thyroid.
Like this is cardiac lecture.
Okay.
I did not prepare for endocrine.
I'm just bugged by the fact that
Yeah, you can Google it. I don't remember, but I know a lot of people have to get their thyroid removed because it's just they can't, and then they have to just take thyroid hormone the rest of their life, which is a bummer. Dehydration, drink a Gatorade. Anemia, iron pills, B12. Huh? Yeah, I mean same thing. Those kind of all go into the. You can also, if you want to take a picture of anything, feel free, or you can just write it down too. I don't care. But just let me know before I erase anything if you want to take a picture of it. It's going. Yeah. Okay. Yeah. So, actual treatments, medication-wise, if you've eliminated all possible causes and they still have tachycardia, what kind of medications can you give them? Beta blockers, our friends, and these end in what? LOL. And why do these help? What do they do? What's the mechanism of action?
They block everyone.
Yeah, so beta blockers are typically called beta adrenergic blockers, and the adrenergic is dealing with adrenaline, which is the same which is the natural form of epinephrine that we give, right? So again, receptors. Yeah, so like adrenaline or epinephrine is trying to bind here. Beta blockers are like, nope, right, it blocks you. So it will drive your heart rate down, blood pressure down, all those things. I like this board. It's very smooth. And it erases, you know, like some dry erase boards, they don't erase good, like that one, yeah. It's super nice. Alright, so, okay. With that being sinus attack, what happens if their sinus attack starts getting even worse and now it's like upwards of 160 beats per minute? What do you call that now? SVT. What's that stand for?
Supraventricular.
Perfect. Okay, so now someone comes with this, their sinus attack is just like out of control. What can you try doing non-pharmaceutical wise to try and deal with it like right now?
Can you do the bearing down to
Valsalva.
Valsalva? I think, yeah.
Get them to call for gag or something.
Yeah.
Yeah,
This
acid on the toilet.
Yeah, this actually, so I'm my blood type is O negative, so I'm a universal donor, and so I always feel guilty every time there's like a blood bus that comes by, and they're always like, "We need your blood to save everyone," and I'm like, "Oh, guilty," and then like I go do it because it's a good thing to do, but I always pass out. I don't know why, if it's like a combination of just like I don't like needles in me, like I'm a nurse, I know it's weird, but like giving a needle to someone else is perfectly fine. But also I tend to have low blood pressure, and I tend to probably not drink as much water as I should because nursing and you don't have time to pee all day. So with all those factors, I just tend to like pass out every time. But I found that like starting to doing like Valsalva like super helps for some reason. I don't know, like tensing your body, like one of the nurses told me that, like, because I told her like I'll probably pass out. She's like, "Oh no, honey, you'll be fine." I'm like, no, I will. I'm just letting you know so that you don't freak out, right? Like, so she was like, "Oh, okay, well, thank you for telling me." Then she said, "Why don't you try doing like the bearing down and like squeezing various muscles?" And I was like, "Okay," I did that and it super worked. I just didn't pass out, so it was super helpful. Just side note. All right, what else? So Valsalva, what else can you do?
Oh yeah.
Yeah. So are you gonna give a carotid massage? No. Who's gonna do it?
Healthcare provider.
Okay, good. I don't want to do that and get in trouble. Carotid massage. I feel like I have to sometimes tell the masseuse to like calm down a little bit because they get their hands like wrapped all the way around, and I'm like, that's the carotid. Yeah. But some guys have like real big hands, you know, and they don't realize. They have a skinny neck and they're just like all the way around. I'm like, maybe back up a little bit.
Knees to chest. Suction.
Yeah. Oxygen is always a good answer, right? And that's because why, like, the problem is the cardiac output. All dysrhythmias, the problem is cardiac output, right? Because it's not functioning properly, so you're not gonna have as much oxygen. So oxygen, what can you do as far as I have a hard time with this word. Defibrillation, but chemically.
Chemically, oh, the amiodarone.
Not amiodarone, starts with an A.
It starts with an A. Adenosine, yeah.
Alright, adenosine.
I mixed them up.
So what do we know about adenosine? Anything?
Chemical defibrillator.
Okay.
It can cause a systolic.
Well,
it will.
It's supposed to, yeah. So you got to tell the patient that. You're like, hey,
Maybe not.
your heart's
Respiratory.
gonna
Yeah,
stop.
yeah.
So the patient said like it feels like they got kicked in the chest. And how long is the half-life? 7 seconds, right? So like you give it, lift that arm up to help gravity get there quick, right? Because some people have like their perfusion isn't great, so like you want to get all the help you can get gravity on your side, and flush it really fast. You know, push flush. Like this isn't one of those meds you want to like sit there and like, you know, take 20 years to push. And they're like, no, they're gonna die. You know, like we need this now. It's not only gonna last 7 seconds, which is a super fast half-life. Yeah, so 7 seconds. Anything else about adenosine I can think of? Anything else in your notes about that one?
She said may repeat, like you said, or no, may repeat with 12 milligram dose. So she said rapid IV push 6 milligrams, 1 to 2 seconds, like you said.
Yeah.
Or closest to the heart, and then flush out.
Oh yeah, that was it. That's what I was thinking of. If someone has an IV in their hand and they have an IV in their AC, which one are you gonna do?
AC.
Right, because that's closer, right? Less distance. Hopefully they have a PICC line. That'd be great. But that's not always the case. You'll find like the sickest patients that need the PICC lines don't, because their veins are all terrible, you know. So like that's anyways. All right, the next one, let's do. What is this?
It's this one.
Well, what does it start as?
Defib.
Then to asystole. Okay, so can you shock this person?
Yes.
When?
Before there is.
Here, right? But not here.
No, it's not gonna be.
Right, so like, I never understood that because I was like, well, why not? Like, you know, they always do it in the movies. Like, Grey's Anatomy, they're like, they don't have, you know, and they clear, and like, well, they don't have, so the point is, they have no electrical activity happening, right? So like, the point of the defibrillator is to interrupt the bad electrical signals, if that makes sense. Like, the ones that are like scrambled, but there's nothing scrambled to interrupt because there's nothing happening. So it would be like shocking a banana. You know, it's like, it's not going to do anything. Does that make sense? But what can you do though for this person? What can you give them? Yeah. So always epi. Epi's your friend, right? Pretty much like, oh, they're dying, epi. Perfect, right? But that's going to do what? What does epi do? Yeah. It's the what did I say? It's the medication version of adrenaline. It's going to increase their heart rate, increase systemic vascular resistance, which will at least, like, you guys ever gardened with a hose? You ever have played with a hose? Do you know, like, if you have it and you turn it on, it kind of slowly comes out, but if like you press your thumb over part of the opening, it like starts spurting faster. You ever tried that? You know what I'm talking about? So it's like, that's a great way to explain systemic vascular resistance. Like, when it's dilated, like the hose is just like the normal opening, it's going to come out slower. But when it's like constricted and you put your thumb over and narrow the opening, like the blood flow goes much faster. Does that make sense? Yeah. So at least that'll like push more blood through the body quicker, if that makes sense. Any questions on that one?
Pulseless electrical activity.
Yeah, so this is a weird one. I actually,
Not common surprise.
yeah, I haven't actually seen this in real life, but in theory, pulseless electrical activity is like their heart is still like producing like electrical signals, but the heart isn't beating, right? So it's just kind of randomly firing, but the muscles aren't responding. So that's why it's pulseless electrical activity.
You can't shock it.
No, you can give epinephrine, right? Epinephrine you can. Same with asystole.
Yeah.
But again, the muscles aren't beating at all. They're just, it's like asystole because it's not moving. So, okay, what else? Did you guys have to learn heart blocks? Okay. I don't know why, but I was in school, like I had such a block about heart blocks. That wasn't meant to be a pun. But like for some reason I couldn't get it, and it was only like years later I was like, oh, it's not that hard. Do any of you have like having a hard time with heart blocks, or are they easy to you?
Showalter explained it so well.
Showalter's amazing. I never
So
had
we're gonna get to her again.
I never had her for like one of the core like adult classes. I don't think. No, but I had her for patho. I loved that. It was amazing.
And now she does a pathway and adult one.
Yeah. So I'm sure she explained it really well, but we're gonna just quickly do it. Okay, so you tell me what this is. Which
So it's
degree?
the first degree.
Yeah.
It's just long.
Yeah, so this is just first degree. How I like to explain it is a little cheesy, but it helps me remember it so much better. Is this is Mrs. P, right? And this is her husband, Winky. Okay. They're kind of having some marital problems, so they're creating some distance between the two of them, right? The distance here. Right? They're not on great terms, you know, they should be closer, but they're having some distance in marriage. Then you get to second degree, or what else? What's the other names for it?
Mobitz type 1. Or is that Mobitz 1?
Yeah, Mobitz 1. So in Mobitz 1, hard to draw. I don't know if this is even still in the video. It is. Okay. So, again, sorry about my drawings. These are the best I can do. So we see that there's a delay here. There's some distance, right? But then the distance
Gets bigger.
oh, look, I did do a proportional. Ha. It's bigger here, right? And then it gets bigger so much that there's not even a QRS there. It's missing, right? So again, they're having marital discord. Mrs. P and Winky aren't having the best time. He goes out with his friends, comes home late. The next night he goes out with his friends. He comes home even later, right? The next night he goes out with his friends. He doesn't even come back, right? But then the next day,
Get rid of him, girl.
the next day, Winky back, right?
Yeah.
So it's Winky back. That's,
Basically long drop.
yeah, so that's how I don't know if I spelled that right. Is it a C at the end or a K?
Oh, you got it.
I did? It's an H? I mean, did I say a C? I meant an H or a K.
It's WENCK, but you're so close. That's
Right there.
Oh, I like it. You put it the name Winky.
Right, so
Yeah.
this is
I love
Winky.
it.
He's gone, then Winky back. Right?
I love it.
That's how I remembered it. I was like, okay, I got this. Because I had a hard time with Mobitz 1 or Winky back and then Mobitz 2. Because I was like, I don't understand.
I gotta remember it.
Yeah, so I'm gonna, okay, I can just kneel down, it's fine. So Mobitz 2, or the second degree or whatever it is, draw this one real quick. Okay, so this probably isn't to scale, I'm sorry. But these should all be relatively the same. Okay, so just pretend they are. Pretend that the distance between the P's are the same. Okay, so Mrs. P, right, she's loyal, right? She's consistent. She's the good one in the marriage, right? It's Winky that's inconsistent and disloyal, right? Because she always shows up and she's always consistent. He's the one that's sometimes there, sometimes isn't. Right, because there should be a QRS here. There should be a QRS here, right? And there should be a QRS here. There should be one here, but he didn't show up, right?
In the video, she said this one's like dangerous or something, like more than the second degree type 1.
Probably. I mean, it's second degree, so I guess that sounds worse than first degree. But does that make sense? So I used to get these two confused, but I was like, it looks kind of similar where like there's missing one here, right? But if you pay attention closely, you'll see like this gets longer, right? Whereas this one stays the same. Does that make sense?
Yeah.
So Winky, the disloyal husband, will show up sometimes he won't, whereas Mrs. P is always loyal, whereas this one, it's like follows a pattern. Longer, and then he's back.
Yeah.
Does that make sense?
Yeah.
This used to throw me off so much, and then I had the marriage metaphor, and I was like, oh, makes sense now. Any questions on that one? So how do you treat this?
For first degree and with atropine or pacemaker. First degree might do nothing.
Yeah.
First degree might what?
It might be symptomatic, so we don't.
It could be.
Yeah, so atropine is always good to try, right? May or not work, huh?
You could do the pacemaker.
Yeah, so that's what's going to go through pacemaker. That'll at least like help pace it better. So, all right, and then the last one, sticking with the same marriage metaphor here. I'll just go below it so you can see them all at the same time. All right, give me a second to draw this one. So this one's going to be challenging. Okay, so I tried really hard to make this random and not consistent. So this one is where Mrs. P is like fed up with Winky and they have an electrical divorce. Okay, so they're no longer doing anything together anymore like they would in a regular sinus rhythm where like Mrs. P and then Winky, QRS, right? With this one, there's just no consistency. The atrium and the ventricles are not communicating whatsoever. So in these examples, you have like Mrs. P is consistent, right? But this one, like, it's just all over the place. Like, you can't measure the PR interval because there's not one really. Like, this one is different than this one, which is different than that one, which is different than that one, different than this one. Does that make sense?
So are they consistent to them? So like R&R is consistent to R&R and PMP is consistent to PMP, but not to each other? Is that the
If there's just no working together, the atrium and the ventricles, usually like the atrium fires and then the ventricle fires, right? Whereas with the heart blocks, at least you have some kind of working together where it's like the atrium fires, and okay, now the ventricle goes, and then it waits again for the P, and then the ventricle goes, right? So at least like the ventricle is waiting on the P, whereas this one, there is no communicating, they're just both going super random. So they call it an electrical divorce, like where like the two signals are just going on their own and they're not waiting on each other. There's not necessarily a P associated with the QRS. They're just disassociated. They're just doing their own thing. Does that make sense?
Yeah, so to recognize it, like nothing is like, the PR is not, like nothing's consistent.
Right. So you can tell this one apart from this one because the PR is always going to be consistent. You can measure it. Like with the little blocks, you can be like, okay, there's, I don't know, 4 little boxes between every single PR, right? This one, there's not. So you can't even give a PR interval. Like if they ask on a rhythm strip what's the PR interval, you can't because like each one's going to be different.
Right.
Does that make sense? So that's where they're basically living together, but like there's no communication and they're just doing their own thing. Does that make sense? So they can be challenging to kind of like at first glance figure out what you're looking at, but that would be the keys for me to tell you is to look at the P's and kind of ignore the Q's. Just like, okay, what are the P's doing? Is is it consistent or is it inconsistent? You know, what's Winky doing? Is he coming back or not? Like, you know what I'm saying? So, does that make sense? Is this helpful? Are there any questions about these? I could not, for the life of me, understand these until.
Type 2, so type 1.
So I should label these better. This is type 1. These are both type 2, but this is Winky back. And then this one's just Mobitz 2. I don't think they have another name for it. Is there?
second degree of people?
Yeah, okay. And then this one's third or complete, whichever way.
Second degree type 2, that one, you said the P's are consistent.
Yes, so these, to scale, these will always be the same distance. So like if you're measuring with the blocks, they will always be the same amount of blocks in between the P's.
And then second degree type 1 is it's just getting longer. Like
Yeah, the QRS is getting further and further away from the P until it fixes itself and comes back. You know, Mrs. P got real mad at him for not showing up, so she yelled at him, and then he got his act together and came back, right? And then it continued the process of that relationship. So, does that make sense? Is that helpful?
Yeah.
Great. I'm gonna erase it. Is that okay? Bless you. Go ahead.
Crispy, you made it go ahead.
Alright. Every time I hear the word Winky back, I always think of you guys know this song? Where is it? It's like I'm bringing Winky back. Like, but it's yeah. So it's not a real song. It's I'm bringing sexy back, but like. But I saw like a nursing video on YouTube. Someone had made one about heart rhythms, and they were saying I'm bringing Winky back, and it was pretty funny. You should look it up.
Now I'm gonna look it up.
You should YouTube it. It's pretty great. Okay. All right. I think that's it for rhythms. There's the bundle branch block, but I didn't really have anything really about it on my notes. So, do you guys know anything about bundle branch?
Which one?
Bundle branch block, or is that not on yours? We kind of briefly mentioned it in my notes, but I couldn't find any other information about it.
This one? No, that's just
No.
that would be good.
There's no.
She's just showing us the
That's
full.
1/3.
Is that third degree?
Yeah, I think so.
Third degree is just a complete. Just another example, I guess.
I don't think that's.
No, bundle branch. Let me see if I have it.
Are you talking about?
Okay, don't worry about that. How do you guys feel about dysrhythmias? What we just did? How do you feel? Pretty good? Better? Pretty confident?
You guys went over the pace rhythms?
Yeah, we did cover that.
Over what?
Pace rhythm.
What about them? I didn't have any of that.
I think it's basically like
Kind of like the other
Just
one.
talking about the
Oh, a little
spikes.
spike.
pacing and
After you wanna look for the few ways in between if they have a double.
I'm not gonna, I don't know much about that. All I know is that the first spike, and you know, they have a pacemaker.
I mean, I don't think there was anything that, oh, well, I guess she wanted us to know what it looked like. Like, just to be able to capture and make sense.
Oh yeah, okay, so sometimes pacemakers don't work, right? So sometimes they will, you know, like when you're looking at the monitor, sometimes you'll see something on the monitor, but it's not actually them. Like it'll be picking up artifacts, like I mentioned, from other things. So sometimes that happens with a pacemaker, even though it's inside of you, like it can still do that. So sometimes a pacemaker will fire when it's not supposed to because they're sensing a rhythm that's not actually you, it's something else. And then other times it won't fire when it's supposed to, like it fails to detect a rhythm that it should be correcting and it just lets it go without being corrected. I think that's what you were talking about. Was there something else on
There
there?
was like, I guess the difference between failure to discharge, so there's a rhythm that it's not sensing it, or failure to capture that it goes off. Like let's say a spike is right here, but it doesn't.
Yeah, so like the heart's just not responding to it for whatever reason. Like it's just like it spikes, but it doesn't happen. And how about yeah, so they have to figure out how to change it. And then transcutaneous pace might be a great option in the term until they figure out what's going on. So
undersensing.
does that make sense?
And then oversensing would be like it's not firing.
Oversensing would be it's going off thinking.
Yeah, oversensing is it's like too sensitive, or it's picking up stuff it shouldn't be, and like firing for no reason, right? Because it's like just extra. Like oversensing, it's like being extra sensitive, picking up things that isn't the patient. Undersensing is when we're saying like it's not firing and not recognizing
On
the
the wrong
rhythms.
spot.
Yeah.
Okay.
So it's just letting bad rhythms go and not doing anything about it. So either way, you're gonna have to call the doctor and be like, hey, fix this, right? Okay. Let's do, you wanna do some CHF? Does that sound exciting? Okay, let's see. I'm going to draw this, probably leave this up for the entirety.
I did everything.
She said it was. Yeah. I think they said the valves are next test, right? That's what she told me.
Burns? No, I got burns was next. Was the first thing.
I saw that valvular things were next on the list.
Okay, I could be wrong. I try to
I could be wrong.
only put what's on this test.
We have
on my
CAD yeah, we have valvular heart disease tomorrow,
Yeah.
and then CAD next week. Yeah, that's all on the test.
So hemodynamics.
See, burns is the first thing on the next
No,
test.
okay. Yeah, you're
So valves is on your test?
right.
I asked her.
Well, it doesn't
Yeah,
valvular heart disease and aneurysms. It says test one is hemodynamics, cardiac, and shock. That's all we're going over.
Maybe it's, didn't she say there's one topic that was on her test? Maybe.
I think it's the valves.
Because she says hemodynamic, cardiac, and shock. Or the valves, not cardiac.
Yeah.
I would ask her because I asked, and that's the impression that I got, but I could be wrong. So I wouldn't want to lead you astray. But I will send you, someone remind me, I do have a video that I made about valvular heart disease from when I tutored this before. It's on my YouTube. I can send you guys a link so that in case it is on your test, you'll have something. So it's only like 3 minutes long. So just someone remind me because I have early onset dementia, I feel like. Overworking and not enough sleeping. Okay, so I'm gonna leave this up probably the whole time. This is the path, I mean, I know you know this, but it just helps sometimes to see it. So blood's in your body, comes in through the right atrium, goes down to the right ventricle, goes up to the lungs, comes down to the left atrium, left ventricle, back to the body, right? It's a big cycle, right? But when we think about CHF, like understanding this pathway becomes super helpful because it just like sets up for like understanding like all the side effects and symptoms. Okay, so start with CHF. What's that stand for? Congestive heart failure. So what does the congestive mean? What does that mean? You know what it's like to be congested in your nose?
Something's in the way, yeah.
Yeah, so like, you know, like you have a cold or the flu or whatever, and like you have all this congestion, right? You've got like all this fluid, right? You're trying to blow your nose, but it's like stuck, right? So that's what it's like in your heart, right? You have fluid buildup, and it's like having a hard time coming out. Usually with your nose, it's because like there's like swelling, you know, like that's preventing it from exiting the passages, because your nasal passages are actually pretty narrow. Like right here, they're wide, but up here, they're kind of narrow. So if they get swollen, it's really hard for fluid to pass through. Same thing with the heart, right? You know, you have the heart, it's a great picture, and then you have, you know, the aorta and whatever. But if this gets swollen or constricted, right, it's hard to get the fluid out, right? Because it's just like those nasal passages, they narrow the opening, and it's like harder to get that stuff out. Add extra fluid overload to that, and now you've got like a big problem because you're trying to get the fluid out, but it's stuck, right? And that's going to cause several problems. So if the heart is stretchy, you know, it's like a stretchy muscle, and you just keep filling it with fluid, it's kind of like a balloon, right? Like you keep putting water in it, and it keeps stretching, right? Hopefully the heart's not going to burst like a water balloon would, because that's a problem. But what's going to happen is you're going to weaken the heart muscle. All right, just like you guys use scrunchies. You know, like you have a scrunchie, you use it too much and it just stretches out and it doesn't really work anymore. It's not elastic. You know what I'm talking about? Like a rubber band, you stretch it too much and now it's like, it's not really stretchy. Same thing happens with the heart. Like you get stretched out from all the fluid, like pressing in. It's like getting really swollen, about to burst, you know? So like it loses its stretchy and now it's not able to like squeeze good, you know? So the congestive heart failure is all about the inability to pump stuff out. So the heart muscle is weakened, and now it's got all this fluid in it. I know this is not how it actually is. And it's having a hard time getting it out, right? So let's talk about left ventricular, you know, starting, because that's generally where the congestive heart failure is. That's the biggest problem. If you have fluid building up in the left ventricle, it's going to back up into the left atrium, right? Because it's not going to be able to pump through. And if this can't come out, it backs up into the lungs. Right. So what are the lungs going to look like? Yeah. So these are lungs apparently. Sorry.
We were all thinking.
It is what it is. Yeah. So the fluid can't get out of the heart, it's backing up, and the lungs is right in the middle between the right and the left side. So now you're going to have fluid build up in the lungs, right? So that's bad. Yeah. What are some side effects, symptoms you're going to hear with a patient with fluid in the lungs? Shortness of breath, orthopnea, dyspnea, how you don't pronounce the P. What else? Cough, you know, those sorts of things. Pulmonary congestion usually goes with CHF. You'll see both of those. But does that make sense why the fluid thing? Fluid pathway?
Bumpy because it's like, it's not able to continue with the normal.
Yeah, the fluid should be going this way.
Yeah.
But there could be several reasons. It could be the SVR, or the systemic vascular resistance of the aorta or whatever. They're too constricted, you know, and it can't get it up there, which makes the heart start stretching, you know, because it's backing up, which weakens the cardiac muscle, which just, even if this resolves itself eventually, now you have weakened heart muscle already, and it's like, well, great, the opening is open, but the pump still can't pump that great, you know. So the problem with CHF is like once you like weaken the cardiac muscle, you can't really fix that. Like there's no like, I mean, short of like a heart transplant and like some medications, you can't like fix a stretched out heart. You know what I mean? You can't like, it doesn't fix itself. So it's gonna be like a recurring issue. Let me erase some of this probably. Let's see what else. Okay, so you have this problem, right? The fluid or the blood isn't exiting into the body. So what's that gonna do to your O2?
Your perfusion's gonna be poor. There's fluid.
it's gonna go down, right? Because your body's not getting enough oxygen. Your lungs are backed up. The gas exchange isn't gonna be fantastic, so your oxygen's gonna go down. So a lot of people with CHF end up needing supplemental oxygen just to like do life. When you're listening to someone's heart sounds, what are some things that you'll hear when you assess a patient?
Extra heartbeat.
What do you call that?
S3.
S3, right? Yeah, also, they call it a gallop just because like I actually haven't really heard a lot of them, but like apparently it sounds like a horse galloping. You know, it has like that extra because usually goes lub dub, but with a third sound it's like da 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 da. It kind of sounds like a horse like galloping a little bit. You like see the movies like the horse is running and it's like da 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 da. It's kind of what it sounds like. What about like location of where you hear the heart?
So she said the point of maximum.
The PMI.
Where it's the PMI
Pack.
is
Yeah.
displaced.
Yeah.
Because
So
the heart is kind of enlarged.
can I erase this?
Yeah.
Okay. So the best way it was gorgeous, right? It should be framed. The best way I can explain this is in a picture. So this is the person. All right, so you got your, you have your heart, right? That's way too large. Hold on, it's really big. Okay, let's try that again.
That's hard.
Like this is their midline, right? So like, and it's kind of angled sideways. And so the left ventricle is like down here, right? So typically you'll see the hypertrophy in this one because this is the one that really pumps it out to the rest of the body, right? Like it goes left ventricle, aorta, right? So this one has to pump like really the hardest. So typically you'll see the hypertrophy here and it'll start like growing, right? So you're kind of making the heart grow bigger in that direction, which, you know, it's opposite. So this is right and this is left. Does that make sense?
Yeah.
So you'll start hearing the heart, the PMI drift towards this way because the heart's growing out that way. Does that make sense? You're nodding but looking at me with
It does.
Okay. And it's a beautiful drawing, I know.
I have 4 kids. That's hard.
I don't know if the camera can even see that. Okay, I'm not even gonna try doing that. There's kind of a glare on the lights too.
I'm missing out on beautiful art.
Yeah, everyone's gonna be so sad they missed my masterpiece. Does that make sense though? Like the heart starts kind of growing, like, you know, like when you go to the gym, you work out, your muscles get bigger. Like the heart's the same way. Like it's gonna get bigger, but it's not good because draw a better heart. So, you know, the ventricles, you know, they're kind of shaped like here's the heart muscle, right? Yeah. And then this is where the blood goes. Blood's in here, right? So if the heart muscle is growing, you have a problem because, I mean, it grows this way, but also like grows this way. So like it cuts into the space where the blood is going. So bigger heart muscle does not mean better, right? Because now you have less blood in here that can be put out, which means that like in order to do the work of one pump, if you're pumping less means you have to have more pumps to have the same volume. Does that make sense? So it's like you have less blood in here. So like what you could have pumped in one pump, now it takes 2. So now it's an even bigger stress load on the heart because you're cutting into its capacity. So bigger heart muscle does not mean stronger. It's worse. The point of maximum impulse. So it's, I mean, when you're listening with a stethoscope, there's parts where you'll hear it louder than other spots, and also everyone's anatomy is different. Like, you know, women have breasts, and you know, some men I guess have breasts too. But like ideally, like there's points where like you'll hear it the loudest, and typically it's like right here. But as it starts to grow, it'll start to kind of shift. So yeah.
Is that the mitral valve that's the loudest?
I think that's what we're listening to. I think that's what they said. Because
Yeah,
H and
yeah.
N,
Okay.
the M is mitral valve, and that's
Yeah.
correct.
So I used to always get bicuspid and tricuspid mixed up because I don't know, because in my mind, like bi means 2 and tri means 3, which it does. And so I was like, well, 2 comes before 3, so this should be bicuspid and tricuspid, right? But no, And it's like, this is actually the opposite. So I remember, like, when you go to the store, you try on clothes, like, you try before you buy, right? Like, you try it on before you buy it, right? So tricuspid, bicuspid. That helps you. I like weird little things. And even if they're dumb and cheesy, if it still helps you to remember, it helps you to remember, right? So it can be lame, but still help you pass the test. Yeah, so I never forgot that. I was like, oh yeah, tricuspid, bicuspid, obviously. You know? Okay. So, all right. So you have this scenario, right, that I just described happening. Let's see. One second. Where was I? So you mentioned the dyspnea, the orthopnea, the cough, the perfusion. Which way is perfusion going down? Up or down?
Down.
Yeah, decreased perfusion. What's happening with their cardiac output? Is it up or down? Down, right? Because the heart's compromised. So what's the body going to do? The body's not going to just sit there and do nothing as this is happening. It's going to try and compensate.
Constrict the vessels and that.
So the first compensatory mechanism I mentioned was like the hypertrophy, which, as we learned, was not helpful, right? The hypertrophy is the getting bigger. The bigging, that's not a word. The enlarging, there we go, enlarging. The enlarging, there we go. Wow, I'm tired. Okay, enlarging of the heart muscle. Yeah, someone said, what was the other thing you guys mentioned?
Increased heart rate.
Yes, so increasing heart rates, because like I said before, like with less capacity with the blood, like you're gonna have to pump double time to get the same output. So increased heart rate.
Your SPR would go up.
Yeah, so your body thinks, oh, okay, well, like the hose, if we narrow it, it'll go faster, right? So, I mean, yes, it does help to a point until it reaches the point where the hypertrophy happens.
So would the blood pressure go up then because of the increased SPR? Or
Yes.
is it going down because there's less perfusion?
It's
Can it do either?
It'd go up. 'Cause
Yeah.
you're getting-
Yeah.
Are we making me think with my everything?
No, it's fine. I worked before I came here,
Oh.
so my brain is just tired. That's why I said things like bigoning.
They're saying okay.
Yeah, that's what I said. Yeah, so I mean, these compensatory mechanisms are helpful in like the short term. They're great. Like your body is really great at fixing like acute problems. So like this would be helpful in like the case of like hypovolemia. Like if you're bleeding out, right? Like you're running from a bear scratched your femoral artery and you're bleeding out, and like your amount of fluid has decreased. So your body's like, well, we can either have no blood come, or we can like speed it up and make sure everything's getting blood, right? So like in that sort of situation, yes, it's helpful. But like when it's chronic and it's doing this like for a long time, not helpful, right? Because then, with the little drawing, the heart muscle starts to get stretched out. It starts to get hypertrophied and the heart muscle gets bigger, which now the heart itself is messed up, even if you fix the other issues. Does that make sense? So the compensatory mechanisms are helpful for a short time. Now, when you reach the point that I was describing, where the ventricles are like really just maxed out, like they're just super not elasticy anymore, they can barely squeeze. It's just like a stretched out rubber band, like it won't shoot very far after it's lost its stretchy. The ventricles start dying in a sense, like not being able to really do anything. So when that happens, what chemical marker are you going to be looking for, like in a lab test? Well, yes, that's more from like a heart attack, but I'm thinking of something else. Starts with a B. Oh, this is in your notes, but I feel like it should be. BNP.
Oh, okay.
You guys heard of that one?
Yeah.
BNP.
But what? Okay.
I was telling them, like when your heart reaches the point where like the ventricles are really just stretched out and they're not really like being able to pump anymore because they've lost their stretch, they'll start secreting BNP, the hormone. That's in your notes, right?
Natriuretic.
Yeah, the brain or B-type natriuretic, whatever it is, natriuretic peptide. I call this in my mind, the body needs peace or needs a pause because it's like worked itself so much that it's just done. Like, you know, like you work yourself to death and you just need to sit on the couch and like you're just tired, right? So like this is when your body has reached that point where it needs peace or it needs a pause, like because it's just overworked, that's when your body will secrete this. Now this is a helpful compensatory mechanism when you've reached this stage, because what does this do? Basically the opposite of the other things. So
it slows things down.
yeah, so this one is a dilator, right?
The uretic is making anything else something to do with.
So this is a dilator. So normally the compensatory mechanisms are going to speed up the heart rate, increase the SVR, increase the blood pressure. This one is going to relax the the arteries, and it's a diuretic also. So this is helpful. Why? Why is a diuretic helpful? What? Right, because remember, C stands for congestive. You got that fluid in you, right? So like part of the problem is you have all this fluid and it's messing up the heart because it's stretching everything out. If you can get rid of some of that fluid, you'll be better, right? So it dilates things, kind of like the heart's like maxed out. It's like, hey, like we've been doing all this for a long time and now we're done. Okay, so ventricles are dying, we need a break. Body needs peace. That's what I said stood for. And it dilates the vessels and it's diuretic to lose some of that fluid. So I mean that's good, but it's also bad because if they're making this, then that's it's not boding well for them because they're not in great shape. Does that make sense? There's also a drug that we have that is the synthetic version of this. Do you know what that is? It's like an actual drug that we can like administer to someone. I don't know if that's in your notes or not.
So like Lasix or what?
It's called Natricor.
Oh.
I don't know if that's in your notes or not, but it was in mine. I don't know if it's an I or an E, but we're gonna go with an I. Natricor, just like epinephrine and adrenaline, and yeah. So this is if they're not producing BNP, we can give them this, and it'll help do the same thing. Is that helpful? Is that not in your notes anywhere?
Not that I see.
Huh?
The BNP's in the book, I think, but we don't have that.
Page 3, apparently.
Where's Natricor though?
I don't know if that is or not. That was in mine, but
You're saying it's on here?
Either way, it's not hard to remember because it's part of the N, like natriuretic peptide. It's basically the same word. So if you see it, you'll have heard of it.
Okay.
Don't worry about it.
So it's an indicator of heart failure.
Yeah.
She mentions
So if you draw labs on someone and they have an elevated BNP, it's like probably not the best for the patient. Like you don't have the best prognosis right now.
she mentions ACE inhibitors, the ARBs, the beta blockers, diuretics, morphine nitrates,
Let me see what you guys have.
as far as so she starts going into this and the medications.
Okay. I feel like we went over these in like fundamentals.
We did,
Okay.
but she's just saying these are
What you give them up over? Do you want to list them off for me?
all the drugs.
Oh, yeah.
Okay.
You said ACE inhibitors.
So your krills, the ARBs, SART, then the beta blockers, diuretics, morphine, nitrates, and WD.
Okay, so we can go through some of these. I know you guys know what they are, but it might be helpful to just kind of refresh like why. Let's start with the ACE inhibitors actually. So What do we know about ACE inhibitors? Yeah,
They
so
relax
take a step back real quick. All of this with the compensatory mechanisms, the ROS, the RAAS is also like lumped in there. I just didn't specifically say it, I mean, because these are the results of it. But the RAAS system is what gives you these results, right? And do we need a quick refresher on that? Okay, so the kidneys will produce renin, right? And then the renin turns into angiotensin 1. What do we know about angiotensin 1? Yes, through the lungs. So Ang1 goes to the lungs, right? And when it gets to the lungs has a special enzyme inside of it, which is called what? ACE, angiotensin converting enzyme, which is pretty easy to remember. So it's an enzyme that converts angiotensin, right? And then that turns into Ang2. And what do we know about Ang2? Potent vasoconstrictor, right? That's where you get this, right? The increased SVR, right? So an ACE inhibitors will inhibit this guy, so that angiotensin 1 is unable to turn into angiotensin 2. So you don't get the vasoconstriction.
So blocks vasoconstriction.
Yeah. And why is that helpful for this situation?
That'll relax the blood pressure.
Right. Gives the heart a break, right? Because like the heart is overworked. It's just like, hey, we can't do this right now. So it gives the heart a break because you don't want to stress the heart out, because then that increases oxygen demand, right? Like when the heart is working harder, like you run on the treadmill, your need for oxygen increases, which is why you start breathing faster, right? So we don't want to stress the heart out. All right, ARBs, the sartans. Sartan. What do we know about these guys?
They're just going to block the receptor sites of the angiotensin.
Yeah, so we have the sartan. I'm trying to not block the camera. It's hard. Okay. So the sartans, they act on the blood vessels, right? So there's receptors on them that can make them constrict or dilate. So they're going to act directly on these and cause them to soften, right? This is like in my mind, I think sartan sounds like soften. So it'd be like the ARBs are softeners, just like sartan. It helps me kind of sound similar. Sartan, soften. So it makes them softer, dilates them, which is helpful again, because one of the big problems with creating CHF was the increased SVR in the first place, right? So hypertension, uncontrolled for long periods of time, can lead to CHF. Does that make sense? It's like the pump to come out, just like your nose, is constricted, so the fluid just backs up and it creates CHF. So if someone has hypertension, they think, oh, I'm fine. It's like, well, you'll be fine for a little bit, but like uncontrolled for a long time, you're damaging your heart, and then you can fix the hypertension, but then your heart's already messed up and you can't fix that, right? Does that make sense? Yeah? Okay, beta blockers. We talked about this one a little bit already before. Beta blockers, they block what? They block adrenaline, beta adrenergic blockers. So they do the opposite of epinephrine, essentially. So beta blockers are on this side, epinephrine's on this side, completely different. So they're going to do what to your heart rate? Right. Right. And this is helpful for heart failure because it gives it a break, right? When it's reached the point where it's like the heart's just not doing well. Diuretic, why is that helpful? Gets fluid out. So it's like getting rid of the congestion in your nose, right? So what diuretics do we know? Lasix, all those. Yeah, the meds that end in sartan, and just a memory trick for me is that I say sartan is soften. Yeah, like it's just one of those kind of things to remember what they do. So it's like, oh, ARBs, oh shoot, what do they do again? Oh, sartan, soften, they dilate the vessels. Does that make sense?
Yeah.
Okay.
So they're similar to ACE, basically. They're both vaso.
Yeah, just a lot of these things will have the same ultimate action, but they just do it differently. Does that make sense? So like sometimes you'll have to treat patients with multiple of these because just one isn't enough, right? Like you'll need to give them ACE and an ARB to get that SVR down, because sometimes like just blocking this isn't going to be enough. You got to do several things. Like, so you'll start with one, and then like that one's helping maybe a little bit, then you add more. A lot of times people like uncontrolled hypertension for a long time, you'll have to like give several medications to keep them controlled. So it's the same end result, but just gone about in different ways. If that makes sense. Yeah, and then nitrates, nitro, you know about nitro, like you put it under the tongue, it dilates the vessels, right? Yeah, because all the blood will be rushing to your head.
Is that the one that can go on the little paper?
Yeah, nitro patch. Yeah, I don't like those because they're very messy.
They fell on the ground.
They're
I
messy.
saw one on the ground. I was like, oh, good thing I had gloves
They don't
on.
stay
I didn't know
on.
it was.
It's also very hard to get an accurate because you're just smearing cream. You know, it's not like a pill.
When you said nitrates do what, lower the heart rate?
The their job is to like massively dilate vessels. So like that'll allow like a big rush of blood. So sometimes you'll see flushing because you're just allowing a ton of blood to come to the area. Same thing like when you put like a hot pad on your hand, like it'll turn red because it's dilating all those vessels. So all the blood is rushing there. That's what nitrates do. So someone's having a heart attack, and that's, you know, a heart attack is generally like there's a blockage, right? So the dilating helps be some space around whatever the blockage is. You know, like this is your blood vessel, and you have a clot there, so you have very minimal flow through the vein. The nitrates will help dilate it, so you have more space, so blood can like go around and get some blood flow. Does that make sense?
Right, yeah.
Very beautiful.
Very.
Does that make sense though?
Mm-hmm.
Okay. See what else we got about CHF. Okay. Let's say someone's coming in and, you know, they're having symptoms and you suspect they have heart failure, but you don't really know necessarily how bad it is or what extent. What can you do? Like, how are you going to diagnose how severe their heart failure is?
Like labs or like what?
Well, that's what I'm asking you. How do you know?
Labs to see ESP is high.
What other diagnostics are there?
Their O2 stat's gonna be struggling. That's what diagnosis.
Yeah, diagnostic tests.
Oh, okay.
Yeah. So X-ray. I used to kind of get confused about like what the different things did, right? So an X-ray, I like to think it was just like taking a picture, right? So like on a picture, you can see size, right? So the information you get from an X-ray will tell you if they have cardiomegaly, and that's where like the heart's getting bigger, growing, the hypertrophy. You can see if there's any pulmonary congestion in that picture. You'll see like a bunch of white, you know, fluid and stuff. But that's all you can really tell from an X-ray. It's just one shot, like a picture. You can see size and fluid, and that's about it. If you want to know anything else, you have to do other things, like an echocardiogram. What does an echocardiogram tell you?
Blood clot.
Yeah, so this one is like taking a video of the heart, right? It's kind of like, you know, when mom's going for an ultrasound for their baby, it's basically the same thing. So you can like see what's happening live, right? So this information will tell you like, okay, what's their ejection fraction? Do you guys know what ejection fraction is?
How much of them should pull?
Yeah, it's measuring their cardiac output, right? So what's normal? Do you guys know what's normal? I think it's 60 to 70. Is normal.
Yeah, it is 65 to 80, I think.
Something like that.
Or
Which is a lot lower than I thought it was. I was like, oh, that sounds pretty low. But like apparently, like when the ventricle pumps, it doesn't squeeze out all of it. Because I guess it has to have some in there to keep it from like collapsing on itself. So yeah, normal 60 to 80-ish in that range. And you can.
Sorry, what did you say echocardiogram was for?
An echocardiogram was like it's like a video. So you're literally watching the heartbeat in front of you. So you can see like, okay, where's the problem, right? Is it the atrium? Is it the ventricle? Is it the right side or is it the left side? Because you can have right-sided heart failure or you can have left-sided heart failure.
Right.
Most of what we've been talking about has been left-sided because left backs into the lungs, right? Now you can have right-sided heart failure, right? And it will go this way. right? So you won't really have lung issues because that's going forward, right? The congestion always prevents it from going forward, it just backs it up. So if the problem's in the right side, it just goes this way, right? So lungs won't really be an issue with right-sided heart failure. However, you can develop right-sided heart failure from left-sided heart failure. It's just like getting really bad. Like it backs into the lungs, it gets really bad. Now the lungs are congested and nothing can get through the lungs, and now it's back into the right ventricle. And now this one starts to get hypertrophy and stretched out, and now this one's not doing well, and now you're just in a really bad situation. Yeah, exactly.
Yep.
So does that make sense?
Yeah.
So if they ask you like what's a risk factor or a common cause of right-sided heart failure, what are you gonna say?
Left-sided heart.
Left-sided, right? So
So in the echocardiogram,
yeah,
it's like an ultrasound, right? So they can.
they can
kind of
watch the
3D
heart pumping
image
right
and
in front of
they
you.
can see the blood
Yeah.
flow and
They can
like
see-
what part it is.
Yeah, they can see the path of the blood and see like where's the breakdown happening. They can diagnose if it's happening systolic, diastolic, which side of the heart it is. It's like literally you're watching a video of your heart. You can see the valves. You can see if it's a valve issue. Because sometimes like this is I guess not as common, but like you can have valve issues that cause CHF. Like if you have a faulty valve, like that's just not like they're supposed to open and let blood go through. But if the valve just stays shut for whatever reason, and the fluid's like trying to get through, but it's like the door is shut, like there might be nothing wrong with the heart muscle or the SVR might be fine, but if something's wrong with the valves, it's not going to get through. Does that make sense?
It's
So
also with the sugar in the atrium, and it's like every time the mitral valve opened, it went into.
yeah, so that you could see that.
Crazy.
You can see that on an echo and be like, oh, okay, they're having valve issues. That's way easier to fix than the whole other scenario, right? Because they can just do valve replacement, right? So, yeah, an echo is super helpful. An echo will tell you, all those things I just said. An X-ray will not. An X-ray will just tell you size and pulmonary congestion, right? Not much else. It can't show you what a video will show you. Does that make sense? So you'll need both of those. You can also, for like more extreme monitoring, you can have a Swan Ganz, yeah. And that'll tell you like the volume, the pressure in the heart, how the heart's functioning. I've never seen one in real life.
It's sort of a ICU picture.
Yeah.
Huh?
That's cool. Yeah, I have never seen one in real life. But yeah, those are the different diagnostics that you can use to get information. Do those make sense? Like what each of those do?
When you said ejection fraction, aiming for, well, I have for 50 to 60.
Yeah, this is a
What do you have in your? Because I think it's really your little.
And also, each hospital is going to have variations in what's their normal.
What's that mean? You said echocardiogram measures cardiac output.
Mhm.
So like
They can see how much blood the ventricle squeezes out each time.
So that's like the
Ejection fraction, the percent that's being ejected out, right? So that's measuring cardiac output. So like for a test, they're probably not going to be like, oh, 55 and be like, oh no, is this normal or not? Like I'm sure she'll be reasonable. So I'm sure they'd be like 40, and you would know, okay, that's bad,
Yeah.
right? So knowing like less means they're not pumping out as much, and if they have a low ejection fraction, that means that their heart has been really stretched out, and so it's just not pumping well. Does that make sense?
Yeah.
So
thinking it could be like more because they have a lot of
yeah. So when the pump's not doing well, that's when dobutamine is helpful. Dobutamine, let's see if I get this right. Correct me with your notes. I think they call it a positive inotrope. Is that true?
Yeah.
Okay. So inotrope is with the strength of the contraction, right? So how I remembered this is like ino sounds kind of like iron, like you're pumping iron, like a buff guy lifting weights in the gym. So it's like the strength, right? The strength of how hard it squeezes. Does that make sense? Because like you can squeeze fast, but do it weak, right? Like a gentle, like really fast squeeze, and that'd be like tacky. Or you can have like a really strong squeeze, right? Does that make sense? So like the inotropes are like the strong squeeze. A chronotrope would be what the other one, like just going really fast. So a positive inotrope increases the strength of the squeeze. A positive chronotrope would make it beat faster. or a negative chronotrope will make it go slower. So beta blockers would be a what? Negative chronotrope, right? Does that make sense? And then epi would be a what? Positive chronotrope, right? Dobutamine, positive inotrope. Yeah. Do those make sense?
Yeah.
I don't know if this will be helpful to you, but like ever since I've heard of dobutamine and I knew it helped with like pumping, I've always in my mind called it dopumpamine instead of dobutamine, like in my mind. So I'm like dopumpamine, and like it helps with the pumping. So if that helps you at all. Let's see what else I have on my notes here. So do you see how all of these med options treat the various problems?
Yeah.
So if I asked you, how would you treat, how would you deal with the fluid issue, you would say diuretic. If I said, how would you give a medication that's going to act directly on the blood vessels to make them dilate, what would you say? There's two options, ARBs and nitrates, right? So just like having in your mind, okay, like there's various problems leading to heart failure. We need multiple medications to treat all the different problems. What else?
Will increase heart rate. Oh no, those are side effects. Will increase contraction, right? And also heart rate.
Does it say it's a side effect, or that's what it's supposed to do?
Side effect, increase heart rate.
Yeah, so that's yeah.
Yeah, because they already have increased heart rate blood pressure.
The CHF starting to make a little bit more sense. Did you guys? Is that the last one you guys did?
Yeah.
So you probably haven't had as much time with it.
You didn't even get to the best.
Oh, really?
Well, I mean, she only did, she has the last little bit to do, and then I guess thought my heart disease.
Oh, there. Do you guys have any questions? Huh?
And I'm saying it may or may not be anything.
Yeah, I'll send you that video though. Just either way, you can have it for this time or next time. Any questions about any of this? Is there anything that's like fuzzy or like you feel solid, or is it like, oh, can you explain that again about CHF?
Oh. She mentioned milrinone or Primacor. Is that the same pacemaker?
Probably. There's probably several of them. What was it?
That's the one that I highlighted for whatever reason. She said for pulmonary edema, look at your ABCs, put them in the high tolerance position in meds as ordered. She said morphine, then nitroglycerin, then diuretics, then dobutamine, then milrinone, or Primacor. What are those?
I don't know. They might have, they make new stuff all the time. When I was in school, they might not have had it. So that might be something new. You could Google it.
I just didn't know that. That's funny.
Oh, she didn't get that far.
This is based on faculty. So she said she might go ahead. Moving on, or are we?
I didn't do it, but they had one on I think last Wednesday. Some other guy did it.
They said they recorded it.
Some other guy, I think his name's Christian.
Okay, so they went over shock.
So shock is actually like not like that much different than this stuff, honestly.
Yeah.
Because I mean if you understand like this, like shock just makes sense. So like with hypovolemia, what do you expect to see with heart rate and everything? That's the compensatory mechanisms. Right, so the compensatory mechanisms are the same regardless of why. So if you're bleeding out, compensatory mechanisms, right? If you're going into anaphylaxis, and anaphylaxis makes your blood vessels just like dilate, right? So that makes your heart rate, blood pressure drop because you're just like relaxing the hose, right? So compensatory mechanisms, the same. Cardiogenic shock, which is basically what we're talking about right now. CHF falls into cardiogenic shock. So does MI, heart attack. Either way, you have damage to the heart muscle. Either you have damage to the heart muscle because it stretched out with CHF, or you have damage to the heart muscle because it was deprived of oxygen and died because of a heart attack. Either way, the heart muscle is not working. Does that make sense?
Yeah.
So either way, you're gonna have the same compensatory mechanisms. And then you have obstructive shock, which is basically a clot or something blocking the heart, tamponade or tension pneumo. So again, same thing, your body's gonna be like, hey, we're not getting the perfusion we need, compensatory mechanisms, right? So like knowing the different types of shock, but really the end result is all pretty much the same, if that makes sense. Because it all tells the body, hey, we're not getting enough blood, we're not getting enough perfusion, we're not getting enough oxygen. Treatments are gonna be similar and the body's gonna react very similar. Basically, all of this fits into cardiogenic shock that we just did.
Right. So, distributive, would sepsis fall into distributive?
Yeah, sepsis, anaphylaxis.
Because of the widespread inflammation is causing the leaky vessels.
Yeah, so this distributive is kind of a weird term, I'm not really sure what that
Because
means.
it's everywhere.
Yeah. So anaphylaxis, you know, you're having an allergy or whatever, your vessels just like vastly dilate, fluid leaks out from the vessels into the periphery. Same thing with sepsis, and so you're having a fluid shift. So the fluid that should have been in your body, in your veins and arteries and pumping through the heart is now just like not helpful. So your body's like, it feels the same as like bleeding out, right? Because your body doesn't really know the difference. It's just like, hey, there's just not enough fluid here. What's the problem? Compensatory mechanisms, right? So same thing with MI versus CHF or cardiogenic shock. Your heart muscle is damaged, whether it be from deprived oxygen in a heart attack or it be from constantly stretching it out and now it can't pump well, you know? So either way, the heart muscle is damaged, and then either way, you have the same compensatory mechanisms. So shock, I feel like, is not that bad if you understand CHF, because this will pretty much be most of the answers. I did want to do this. Someone made this little chart when I was in school, and it was super helpful. Is it okay to erase this? You guys done? Okay, I'm gonna make this chart for you because it was super helpful to me. This is back to hemodynamics, which we haven't really done much of, but this is,
Whoever did the ASAP last week.
yeah, they should have a recording of it, and you should be able to watch it, so hopefully that will cover most of hemodynamics. I don't feel like hemodynamics is that hard. It's just really about Swan Ganz catheters mostly.
Yeah, it really was.
So, and then the rest of it's like,
We know those numbers.
yeah, to memorize the numbers, honestly. But this will be helpful, like just understanding it. Okay, so over here you have the things that that can be affected. CVP, which stands for what? And what does that mean?
Well, that one is like the pressure on the right side.
Yeah, it indirectly tells you like what the right side of the heart pressure is. So we'll just put like right side here. It's also called like the preload. And then the wedge, what does this tell you?
It's the left side.
Even though it's technically in the pulmonary artery, it's reflective of what's happening in the left ventricle or the left side, because why? The left side would back up into the lungs, right? So this is the left side. Then you have cardiac output, systemic vascular resistance, and perfusion. So these are things that change. Now, this might help you visualize if you're a visual person. Okay, so first scenario, let's say you have someone that has right-sided heart failure. Right-sided heart failure. What do you expect to see with these things? So central venous pressure or the right side what do you expect to see? Up, down, neutral. So this is the pressure, right? Central venous pressure. Yeah, it's remember like
It's because they're failing.
right, it's failing to pump well, so it's getting backed up, right? So the pressure is gonna increase, right?
Yeah.
Just like a water balloon getting more and more
Yeah.
backed up in there.
Yeah.
What do you expect to see in the wedge pressure?
Probably, I want to, well, if they have left-sided failure that caused it.
Don't overthink it.
Okay.
Just right-sided.
Unaffected?
Nothing, right? Because remember that I had written up at the top, body, right atrium, right ventricle, lungs, left atrium, left ventricle.
Right, nothing.
The wedge comes after the right side, right? Because it's in the pulmonary. So this won't be affected, right? This will still be normal because this comes after the right ventricle. Make sense?
Yeah.
So the pump always goes backwards. Doesn't affect stuff in front of it. Does that make sense? Okay, what about cardiac output? Down. Not pumping well, output's not going to be great. What about systemic vascular resistance? Why is it going to be up? Compensatory mechanisms. You're not getting enough cardiac output. Whenever this is low, this is going to be up, right? Because your body thinks, oh shoot, I'm not getting enough. Compensate. Yeah. What about perfusion? Is that going to be up or down? Down. That makes sense? Okay, next scenario. That is not a straight line. All right, now we have left heart failure. Same thing. What are you gonna see? Well,
It might
just
not initially.
right, not initially. Nothing, and then it will, right? That's confusing. So it'll be
Perfect world.
great. Eventually, it will back up enough to it where it affects the right side. Does that make sense? Not immediately, but it will. Wedge pressure. Obviously up, because it's the left side that's failing, and this is representative of the left side. So wedge pressure will be high. What do you expect to see cardiac output? Low. This is going to always be low. And then this is always going to be up, and this is going to be down. All right, last one. Hypovolemia. And this really could go for pretty much shock in general, like, but they just had its hypovolemia. What do you expect to see for right-sided pressure? Decreased, right? Because there's not enough fluid.
Going into the
Right?
side, yeah.
There's your body's freaking out because either whatever, anyhow, there's a gazillion different causes for shock, right? Hypovolemia being one of them, just not being enough fluid. So the problem isn't that like the heart's getting backed up. The pressure, there's just not enough fluid, right? So the pressure is going to be low, right? Which means that this will be also low, right? Which means this is also low. And so what does your body do? Compensate up, and because this is down, right? So you notice a pattern with anything?
Yeah.
Always low, always high, always low. Just these things that kind of change a little bit. You want to take a picture of that before I erase it? Is this helpful? Kind of just helps to see like big picture what's happening.
Yeah, so the pressure, when it's dry heart failure, the pressure is high
Which one are we looking at?
on the right.
This one?
The pressure really high when it's trying to like.
This one?
Choking is pressure.
Yeah.
Well, you have right side heart failure, which was just like when I drew the picture with the left side heart failure, it's the heart muscle is failing to pump, right? Because it's got too much fluid and pressure in it, right? It's like stretching the heart out. So that's why it's heart failure, because the heart is like, the muscle itself is getting weak because there's too much fluid, whatever, there's all that buildup of pressure, right? So that's why it would be the same thing if you had left-sided heart failure. Eventually it will back up into the right side, right? This is just another way of saying like right atrium, like left ventricle.
For the wedge, she did say that if you can't measure the wedge, There's another, I forget. Cause the wedge pressure is the one that always kind of confuses me, like I understand what it does, but I just don't know, like,
You don't know what.
I don't know.
Oh,
It's kind of confusing, yeah.
They would have to put it all
Like
the way
another
through
way
the
let me
heart,
draw a picture.
up-
Are you guys done
up
with
through
this?
the bicuspid, all the way into the pulmonary,
So they couldn't get it.
pulmonary arteries.
Hold on,
Like up in there, and if they wedge it for just a sec to check that pressure, and then they pull it back.
let me draw a picture. I'll like
Picture, they'll get a good
But why
picture of
do
the
they
actual
temperature one?
temperature.
Yeah, they take temperature.
Yeah, it just says that Swan has like one supposedly. I don't know what you mean.
Yeah.
like what does that serve?
Yeah.
I don't know in case they want a really accurate temperature.
I was gonna say that'd be an immediate temperature.
Like it's better than axillary or tympanic. It's just
Or
like
any.
I don't really know, but maybe they just want a really accurate temperature.
Really internal.
Okay, this is obviously not what the heart looks like, but we're just gonna go with it. Okay, so what is this? Okay, so the subclavian is usually what they go through, right? So I'm just gonna put subclavian, and that feeds into the right atrium, right? And then you have your valve, you have the right ventricle, then you have the pulmonary arteries. I'm gonna do PA, and that goes to what? Trying to make that look different this time. So that goes to the lungs, and then from the lungs it goes where?
To the right, or left atrium.
Yeah, so the left atrium and the left ventricle, right? So
You can't go all the way through.
if you have a catheter going into the subclavian, which is like subclavian-ish here, going down, going into the right atrium, has to go through this valve, and then it has to go up through here. I don't know how you go up through the lungs, right?
Those capillaries.
That doesn't make sense to me, you know, it's because it has to go through capillaries and then back to veins and arteries. Come down through here and then get a reading for that, right? Like that's not possible. So they don't do that. And they're just like, well, if this is high, it's probably because the ventricles are messed up, right? Because it goes left ventricle, left atrium, lungs. So if it's already affecting the lungs, you already know the ventricles are messed up. Does that make sense? So they don't necessarily need to go all the way. I mean, I'm sure it'd be helpful if they could, but they just assume that if it's already backed up through the lungs to this point, the ventricles are messed up, right? So what they do is they have a balloon here, and then every now and then they'll inflate it to see how much pressure is exerted on that balloon. Obviously, you don't want to leave it inflated because now you just created a false clot and just gave them a heart attack, or a pulmonary embolism, I guess I should say, because there's the goes there. And then they get some pressure, they correlate that to this side, and then you deflate it so they don't, die. That'd be unfortunate. So, does that make sense? So that's what the Swan or Swan?
I think it's just Swan.
I always want to say Schwann. I don't know why it's Schwann.
There was something
It is just Swan, isn't it? Okay, less fancy. So yeah, that's the. Does
Thank you, that's more clear now.
that make sense?
Yeah.
And then the CVP one, well, just like they have a balloon here, they also have one here, right, to get the pressure of the right side.
Two, but they're two separate.
Yeah, I don't think you do it the same. It's two different spaces of the catheter. Now, I think, don't quote me on this, but I think I remember learning that sometimes the catheter can like advance, like because the movement is going this way, right? And if you have a big old balloon, just like if you throw a beach ball in a river, it's gonna go downstream. If you leave this inflated, it'll like go down and it could get wedged in the valve or slip into here. And then you'll know that happens because the readings will just be weird.
Yeah, she mentioned it.
Did she mention that?
It's like, it's tickling.
It's supposed to be like different like wavelengths, and so you're just like the readings are super off. Like, okay, it's backed up. Let's deflate it and bring it back.
You can kind of tell where it is just by the reading.
Yeah.
Okay.
She shows the
Those are bigger, yeah.
So the readings will be way higher. Like, whoa, something's not right. So the balloon probably went down too far, being pushed along downstream, so to speak.
that's cool. That's probably.
Does that make sense?
Yeah, she does have.
That should be it. I mean, obviously there's more to hemodynamics, but if you understand this, memorize the numbers, you're pretty good. Right, and knowing what this is for, you use these for people that have really bad heart problems, so you can really monitor what's going on. So heart failure patients will be a great candidate for one of these, right?
Usually they come like after surgery, they put Swan.
And in my notes here, I mean, it'll say stuff like factors that can affect your CVP. Well, we should already know this, right? If you have too much fluid, circulatory overload, that's going to increase the pressure in the heart. So that's going to increase the CVP. This is CVP.
Kidney failure?
Right ventricular failure. You know, obviously it's going to back up to that. High pulmonary pressure, right? If you have high pulmonary pressure, where is it backing up to? Right. So that hemorrhage is going to affect CVP, but in which direction? Hemorrhage is bleeding out. That's going to make it go down, right? Because there's not hardly any fluid. So no fluid, no pressure. High fluid, high pressure. Extreme vasodilation in the case of anaphylaxis or sepsis. Which way is this going to go? Down. Right? So like we have notes and notes about like things that affect wedge pressure, things that affect CVP. If you understand CHF, got it. You know? That makes sense? That's helpful.
Think of allergic to room.
Huh?
I'm allergic to room. You are? I don't know.
We have like 5 minutes. That went by a lot faster than I thought it was going to. Does anybody have any last minute questions about anything?
Why don't you do another one of these?
I don't know. I mean, because as far as I know, it's just whenever Bonnie Hunt feels better. I did tutoring for like 5 years through the nursing program, so I enjoy it. They might be, because you guys have, you probably have been missing out on some ASAPs because she's been out. They might be able to like schedule some more that I can come do if you ask them. Because it helps me keep fresh and I like doing it. So.
You let them know that you're willing to do more. Yeah, we'll let them know we like you.
No, I mean just ask them and they'll message me. Where's the mouse?
Are you stopping it?
Yeah, but I don't know.
Is that it right there? Is that?
Here it is.
Oh.
Stop.